Hi, everyone. Either good morning or good afternoon, or whatever part of the day you're in your various time zones. I'm Diane Powers. I am one of the co-chairs of this special interest group. We are now a special interest group, and that happened recently. Our charter is posted to the Basecamp files area if you want to look at that, and it articulates everything about being a special interest group, and especially for people to be thinking about the electing new folks for next year. So one of our co-chairs, which is Tisha Dean, will be continuing as co-chair next calendar year, and will be voting in someone to be her co-chair starting in January. So be thinking about that. The other thing I'd like you to think about is, and I think I posted to this on the listserv, is the Collaborative Care Awards. So an award will be presented at the CFHA annual meeting in Phoenix. And the criteria for that are listed in my message on Basecamp. If you've got any questions about that, or you can't find that message or anything, you can feel free to reach out to me and Tisha. The nominations period ends at the end of June. So please, please think about colleagues that you'd like to nominate. You can nominate yourself. But we'd like to see a nice group of folks. You can't nominate co-chairs of the special interest group, and we can't nominate people either. So, I've got some ideas of folks that I think should be in that pool, but I'm not able to do that. So I really encourage all of you to think about who are folks who've made a significant contribution to collaborative care over the years, and in particular also I think in CFHA, and please get those nominations in. And again, if you have any questions about how to find the nomination materials or any of that, I really encourage you to reach out to me or Tisha. So for today's meeting, we are going to be talking about treatment of OUD in primary care using a collaborative care approach. And we have three people who are going to be sharing their experiences with us today. That is Dr. Jen Thomas, Dawn Harris, and Heidi McKinney. And so the three of them are going to talk about their experiences doing this work. And then we'll make sure that there's also time for, sort of open Q&A with them. And I think Jen has some slides that she's going to use, and I would encourage folks to, ask questions along the way and make it a real sort of interactive conversation all the way through, instead of just kind of holding your questions until the end. So with that, I'm going to turn it over to Jen.
Okay, great. Thanks, Diane. Good to see everybody. So excited today to talk about opioid use disorder and collaborative care. That's definitely one of our babies in our health system with the CHAMP study that we've been so fortunate to partner with AIM Center on. I'm going to try to share slides.
Jen, it might just be me, but your audio is discernible, but a little bit soft.
Soft. Okay. Are you able to see slides, guys?
Yes, we can see the slides and we see you, but if you could either up more or do something with your audio settings, that would be great.
Is it any better if I scoot in?
Yeah, it's better.
Okay, sounds great. All right, yay.
Just project like you're on stage.
Yes. All right, we will get that stage voice going. All right, well, good to see everybody. Again, slides, but definitely interactive. We're just going to chat about our experience with incorporating opioid use disorder treatment within collaborative care in our neck of the woods. So Dawn Harris is a LCSW that works with me and my team at Morris Hospital in Morris, Illinois. We're in northern Illinois, about an hour and a half southwest of Chicago. So definitely the rural edge of suburban Chicagoland. And also joining us is Heidi McKinney. I don't know if you wanted to say hi too before we get started.
Yes, hello. I'm in Vancouver, Washington, work for Peace Health at their Southwest Family Medicine Clinic. We are a residency clinic. So we do collaborative care. We are fully integrated. And I am also a part of the University of Washington CHAMP study as a care manager, or the behavioral health side of it.
Wonderful. That's great. So yeah, so all three of us are part of AIM Center CHAMP study. We'll talk a little more about what that is, but it's literally studying how does it work to do collaborative care with people with co-occurring opioid use disorder and mental health? How do we approach them in primary care, screen them, engage them in treatment, and get them treated? So yeah, it's been a really great journey doing CHAMP with the UW folks. So let's jump right in. I was hoping to kick us off with just a real life case. So thinking through somebody in primary care. This is Joe. He's a middle-aged guy. He comes into the primary care office and says he needs to get a new doctor. His former PCP is retired, and he's hoping that your PCP can take over his care. He's got some chronic back pain, back injury at work. He's been taking Norco 10-325 about 4 times a day for several years. And he says he's doing really well with this. He's able to work in construction. It controls his pain, keeps him functional. He's married. He has an adult son, stable housing. He's done construction for 35 years. Otherwise, healthy man. He has hypertension, takes some hydrochlorothiazide. Your office did a point of care urine drug screen, and it showed opiates, but it was negative for other substances. So in considering prescribing for him, maybe you pull up your prescribing monitoring program, your PMP, and you do note that he's been consistently prescribed 120 tabs of Norco on a monthly basis. So when you're interviewing him for your initial primary care visit, he's saying, I get 4 Norco tabs a day. I wonder if, doc, can we bump that up to 5 or 6? I run out sometimes a little early. There have been a few times where I had to buy a couple extra tabs off my coworker, but only prescription tabs. He comments to you that I would never do any street drugs. That stuff's not safe. You never know what's in it. But, in inquiring your conversation with, okay, well, what role does the Norco play in your daily life? He does say he spends quite a bit of his time thinking about when he can take his next pill. He's missed a few days of work, a couple family functions, because when he does run out of his meds, he feels sick. He feels like he's nauseous and achy and just hasn't been able to function well when he runs out early. Other substance history, he had some issues with alcohol or binge drinking when he was younger, but no current alcohol use of concern currently. And because it's primary care and you do collaborative care model, you've screened him for depression, and his PHQ-9 score is a 10 today. So as we kind of go through and just kind of talk about his case, be thinking of things and chime in on these kind of things to be keeping in mind. Does Joe have opioid use disorder? Do we know that yet? Can we tease that out? Do we have concern for that? Do we need further investigation? And how comfortable would you be in having that conversation with Joe? I don't know about all of you guys, but OUD training, I'm a family medicine doc. That was never something I was formally taught in training. It was always, okay, refer out to a specialty addiction center if someone had opioid use disorder. So hopefully that's changing and more PCPs are getting comfortable having those conversations, but it might be something that's new to your team. And those medical providers that you work with, if you're a care manager or a site consultant on a CoCM team, are your medical providers doing OUD diagnosis and treatment, or is this more of a refer out situation? And then thinking through how collaborative care could support someone like Joe. So really excited to get your guys' point of view on how we can help him with the CoCM model. So again, my background, I'm a family medicine doc. I got really interested in doing addiction medicine work through the CHAMP study. So our site joined the AIM Center's CHAMP study, Collaborating to Heal Addiction and Mental Health, in late 2019. And that's where I started doing buprenorphine prescribing for patients in my primary care practice. And I really enjoyed it so much that I went and got board certified in addiction medicine through ABPM in 2021. And it's become a real blossoming part of my primary care practice. So some of the comments and things we'll talk about today is just a compilation of some ECHO series training, some addiction mentor docs that have taught me what I've learned, and just hoping to kind of share that conversation on how we can bake that into the work we do in managing chronic disease in primary care. So, and I forget where this came from. Someone had the beautiful acronym. Think of the 3 C's when you're talking about substance use or risk of misuse with your patients. You don't have to go down a checklist, but you could say like, hey, are you having any loss of control in your use? Are you having continued use despite it having negative consequences on your life? And are you having cravings to use the substances in between episodes? These kind of 3 C's are things I keep in the back of my mind as things I can weave into just a natural conversation. And if they're saying yes to these, then we might need to dig in more to, true criteria. So what does DSM-5 say about the criteria for OUD? So it's things you're probably familiar with, but we'll review real briefly. So just taking opiates in larger amounts or for longer periods of time than you intended.
So
Once it's-
Jen,
Yeah,
your
go ahead.
slides are not actually advancing. I was
Oh,
just going to say
no.
that. And
I'm so
somebody
sorry.
somebody
Yeah.
else observed that as well. So
Oh, I'm sorry.
that's
Shoot.
okay.
I don't know what my deal is with slides.
We see Joe's case, but as you move
As
through,
I'm seeing him. Yes, crud. Does anybody else? I'm so sorry. I don't know why this keeps happening to me. I don't know if Diane or Heidi, Don, if any of y'all could share slides. I'm so sorry. I don't know if what
Jen, when I've had that happen, if I don't go into slide mode, if you just
Oh,
kind of
okay.
like click down,
Okay.
that is another way that that could work.
All right, thank you.
It's happened to me too.
Laura. I feel like I'm so deficient with with sharing
There
slides.
with you.
Like, oh my goodness, it's crazy. Okay, let me try share and then get out of slide mode. Let me see if that works. Because the slides are cool. It's better with pictures.
Yes.
Everything's better
It's
with pictures.
advancing now.
them now.
It
Yeah,
is
we see
advancing
them
now?
now. Yeah.
Okay, can you see that?
Yep.
Yes. All right, cool. Thank you. Oh, I'm cursed. Anyway, all right, DSM-5. Can't cut down even though you want to. Maybe spending a lot of time obtaining or recovering from your substance use, cravings, failing to meet those obligations at work, school, or at home. Maybe having social or interpersonal problems. Maybe your friends or family are commenting about your use and it's causing difficulty in your relationships. Maybe you're giving up activities that you previously enjoyed because of your use. Physically hazardous, you're using during physically hazardous situations. So maybe you're driving or working and continued use despite knowing that you're using in those unhealthy or risky situations. Pointed out too, when I was taking addiction med training, they really, Dr. Saxon's my mentor, he's been doing addiction med for many, many years. He's one of the PIs on the CHAMP study. He mentioned to point out to us that, you know, if someone's prescribed opiates, they will have these bottom two, tolerance and withdrawal, right? If you get prescribed Norco TID by your primary care, over time, you'll develop tolerance. And if you abruptly stop those prescribed Norco, you will go into withdrawal. So again, there's this asterisk that these criteria of tolerance and withdrawal are, you know, part that they wouldn't count as toward OUD criteria if someone's being prescribed opiates solely under medical supervision. So just keep those in mind. If someone only has tolerance and withdrawal and they're prescribed Norco, we're not going to label them with a use disorder diagnosis. These other criteria have to be present. So talking about meds, I don't know about you guys, but this was the most intimidating thing for me as a PCP and the whole, can you treat OUD in primary care? It was the whole, all right, what about this whole Suboxone thing, right? You don't have to take like a class or have an X waiver. So that was definitely a stumbling block of where I think a lot of PCPs sort of shy away from learning this. But I would just share that it's been really empowering to get some additional training, and it's really not as overwhelming or difficult as you might think when you get started. A good mentor can make all the difference. So what are the meds we can prescribe for opioid use disorder? Methadone obviously has been around for a long time. This can only be prescribed by clinicians out of OTPs, those opioid treatment programs that are federally regulated. So there's a little barrier there with, you know, distance, and some programs distribute, you know, a daily dose, or then they'll get a take-home dose if they're enrolled in the program for a while. So methadone, though, is a very effective long-acting full agonist that can help a lot of people with OUD. So that's one option. Naltrexone is another one. So most folks think of this as the Vivitrol shot, which is monthly, and that's a full antagonist of the opioid receptor. So while methadone, in the picture on the right, you know, occupies that receptor and turns it on, naltrexone blocks the receptor, so it's an antagonist. So buprenorphine is the third one, and it's kind of got its neat little property in that it's a partial agonist. So when you see the figure, oops, on the right, can you see the Suboxone or the buprenorphine figure there? You guys seeing that on the right?
Yeah, we see it. Yeah.
Okay, perfect. So think of it as partially turning on the receptor. So with that, you'll have how we can use that as a FDA approved med is that it turns on the receptor partially, but it has some other cool effects, that it has a ceiling effect where it comes to respiratory depression. So if someone overused Suboxone and took another dose and another dose, they're not going to have that ongoing effect that can make them nod out and have respiratory depression, which can be fatal. There's also limited effects of the euphoria that you can have some patients will say they get a little euphoria with Suboxone, most say they don't. But these are some of those properties of why it can be harnessed as a medication to help people get off of the full agonists like fentanyl and heroin. So it comes in sublingual films and tabs. There's also a sub-Q injection called Sublocade. Good news on the prescribing front, the DEA did eliminate that X waiver just in January. So previously, if you were a physician, you had to have 8-hour training in buprenorphine prescribing to obtain your DEA X waiver. I think it was 24 hours if you were a nurse practitioner. So that is no longer the case to help with increasing access to this life-saving med. So any prescriber now that has a DEA license can prescribe buprenorphine. So maybe this is something that will catch on for more primary care. So here's just another figure showing that opioid receptor. So buprenorphine has a high affinity to that receptor. So it's going to be more attracted and bind more tightly to the receptor than heroin would. And again, that's one of those properties that helps cover the receptor so that it makes people less vulnerable to the effects of a full agonist like heroin if they did relapse and use. This is another nice picture too, to think about that ceiling effect, right? So say you were doing fentanyl or heroin and you just kept taking a higher and higher dose, the effect would be, you know, increasing over time. But with buprenorphine, you get a plateau here that has a ceiling effect, limiting the respiratory depression, which helps safety and limiting the euphoric effects. I think these are just good pictures to keep in mind, because in practice, and I know Don and Heidi will comment on this, folks are going to ask you about like, well, why is this med appropriate? Is this not just one substitution for one addiction, one, you know, addictive med for another? So being able to speak about those properties can help you communicate that to your patients. So I highly encourage you to dig in and learn this cool nerdy stuff. All right, so let's say Joe did come to us. He did say, yeah, you know, that Norco use, it is causing a problem. I am getting withdrawal. I'd rather not take it. And he might say, okay, I'm interested in talking about buprenorphine. How could we get started with this? So with an induction visit, this is your first visit for someone that wants to start buprenorphine. You're going to need to discuss with them that they have to stop those full agonist opioids for at least 12 hours, sometimes 24. So in his case, hydrocodone, yeah, probably at 12 to 24 hours, he'll start going through withdrawal. And that number of hours is just an approximate. It doesn't have to be by the clock 12 hours. What we really want is for signs of withdrawal to emerge, not just you're feeling cruddy. It's like we need to see those physical withdrawal signs. So things like goosebumps, runny nose, tearing, restlessness, maybe you get nausea or diarrhea. When those signs start to emerge, that shows that you have enough opioid receptors open for that buprenorphine to bind. The caution is that if you start too soon and you've got too many receptors occupied by heroin or fentanyl, and you take buprenorphine, the risk is then going into what they call precipitated withdrawal. So what's supposed to happen is you go into withdrawal, you take Suboxone, you feel better. If you go into withdrawal, take Suboxone too soon and you feel worse, that might be a precipitated withdrawal situation. So just really coaching up patients of expectations of how to know when it's time to start, I think is the biggest piece of getting someone on meds, is just having those conversations of how long to wait and when to start. Now in the era of fentanyl, it makes it a little more complicated. Sometimes folks have to wait 24, 48 or plus hours till they're ready to start, because if we start too soon, people might comment on precipitated withdrawal symptoms. So fentanyl has made it a little more complex. Historically, a lot of folks did inductions in the office, but these days, the vast majority of people will do home induction. So you'll just write your Suboxone script to the local pharmacy, give them the education, they'll go fill it and start it in the home setting where they're more comfortable. All right, so what dose do we often start with? Usually a 4 or an 8 milligram buprenorphine is the starting dose. The goal of that first day is just to get through withdrawal. Now, remember, you've got other tools in your toolkit like clonidine, hydroxyzine, ondansetron, loperamide, just to help alleviate some of those symptoms so they can get through withdrawal and get stabilized on the meds. So how you want to talk your patient through this is, okay, when you get those moderate withdrawal symptoms and you start your first dose, wait an hour or two and see how you feel. If the withdrawal subsides, you're good. If you're still feeling the goosebumps and the runny nose and the body aches and the nausea, take a second dose. Most patients, and FDA says, you know, max dose 16 milligrams on day 1. Specialty, you know, group consensus of, you know, addiction specialists say that, yeah, fentanyl era, you might need a little bit more than 16 on the first day. And then I showed here like a prescription. This was a really helpful tip that we got in one of our Echo series is, okay, like what does a script actually look like? Well, how do I write it? How do I send it to the pharmacy? So you just say, okay, 1 film at the onset of withdrawal, repeat dose in 1 to 2 hours if needed, max dose 16 milligrams in 24 hours. So we usually give them enough for a week supply and see them back in the office in a week. You might see them sooner. You might do even like a telemed follow-up visit just to see how they're doing, or have maybe your care manager or nurse check in with them. But those are kind of the nuts and bolts of doing the prescribing for that induction visit. Other good practices is to make sure they have a Narcan prescription. So in case of opioid intoxication, They can use Narcan, the intranasal naloxone, as a reversal agent. Most places, this is over the counter. I check, I'm not sure it's national. I think it is nationwide. Check your state though, but I believe you can walk into any pharmacy and get Narcan over the counter now. There's a lot of community efforts, harm reduction efforts that they give it away at all sorts of churches, OB offices. I mean, you name it. There's a lot of push to just have Narcan widely available to prevent overdose death. If you are going to consider doing this in your primary care practice, it'd probably be a good idea to get some consent and patient agreement forms rolling. If you're not familiar, really love the Providers Clinical Support System, PCSS, wonderful addiction psychiatry folks. They have a mentor program where you can request an addiction doc to be your mentor if you're new to prescribing. Dr. Saxon's mine, and everything I know about treating addiction I learned from Dr. Saxon. So it's really, really helpful thing. They've got examples of treatment agreements and consents. There's wonderful patient ed and family ed handouts. So check that out if you're not familiar. PCSS is really good stuff. And then really just other education is that as a opioid, buprenorphine, can be unsafe if combined with other sedatives. So while it itself has that ceiling effect with respiratory depression, a relatively safe med, in combination with other sedatives, benzos, excessive alcohol, respiratory depression can happen. So you just want to make sure you counsel them to try to steer clear of those things while they're on buprenorphine. Another good thing I think that we learned in our launching of MAT and OUD care is just how to use point of care urine drug screening. As a PCP, I never did urine drug screening, so we started doing MAT. So I was something I knew very little to nothing about. But the addiction training that I had, they really hammered home that the urine drug screen is more to provide information. And it's okay to have that conversation with your patient up front and say, we're not doing this as a gotcha. We're not saying, oh, you've got pot or cocaine in your drug screen for your Suboxone follow-up, you're out of the clinic. I mean, a lot of patients will have had experiences in the past where drug screens are very punitive, right? Where results can get them, in trouble. And so, the way you frame it with your patient is just, this is information. We just want to see what's in your system, helps us know how to safely treat you. And ASAM, FYI, they put their guidelines out too, that stimulants, marijuana, other things that are in the urine drug screen shouldn't suspend opioid use disorder treatment. However, they made a comment that if people are using multiple polysubstances, they may have a poorer outcome. And if someone is repeatedly using benzos or other sedatives, you might have to consider suspending treatment for that risk of respiratory depression. So it's more case by case, but just hammering that home of the urine drug screen is not supposed to be a punitive thing. That was definitely a learning point for me. I hadn't really been taught that approach before. And extra fun fact for fentanyl, that the point of care ones you can do in the office, there are no urine drug screens point of care that detect fentanyl. So as much as we might try to go, ooh, is there fentanyl in this person's heroin supply? And there very likely is in today's drug market, it won't show up on a point of care one. So we might even have to just assume that fentanyl is present. So ask your patients. They know a lot more about their lives and their use than we ever will. So the drug test, presumptive versus definitive. There are definitive drug tests out there. Those are the qualitative ones that you would send out, to the lab or specialty lab versus screening. So if you think of the iCup, that's a product you can get in a primary care office. That's a qualitative screen. It shows you whether a substance is present or not. It's an immunoassay. It's simple. It's a screening test, and it's relatively cheap, 10 to 15 bucks. The definitive test, the qualitative, that's different chemistry. That's your mass spec, gas chromatography. That's a complex confirmatory. And if that is needed to change your plan of care, if that's something where you absolutely need to know for sure what's in the system and how much, that test is there for you. But keep in mind cost. One of our addiction medicine faculty at the Carl Fellowship, Dr. Basante, was like, think of this as ordering an MRI every time someone came in for a follow-up. If you did a quantitative drug screen every Suboxone visit, that would be really costly to the health system to do that lab each and every time. So maybe there's a role for a screening test. And just putting a plug in here to be aware of language. The stigma language creeps in a lot in our care of addiction patients, and even your staff might use terms like clean and dirty urine. Maybe you try to reframe that and say, oh, this substance was detected or undetected, using more of use disorder phrases versus abuse or addict. That stigma-laden language is really out there. So just be mindful of that. That's just a point that I think as we learn, know better, do better as we grow. And then I just popped in a couple FAQs because these people, you will ask, your patients will ask you these types of questions, and your staff, if this is new to your MA and the people that you're working with in primary care, these things might come up. So one of the big ones is, okay, so what's the deal with the naloxone? I get buprenorphine, it's a partial agonist. Why put a blocker, an antagonist in there with Suboxone? Why is that even present? Well, when you take sublingual Suboxone, that naloxone has very little bioavailability. So you put it on your tongue and you absorb it, that naloxone doesn't really do much. Now, if you misused your Suboxone and tried to use it intravenously, then that naloxone has a much greater bioavailability. I can't say that word today. So essentially it's there to help reduce the risk of diversion and misuse. Okay. Other questions you'll get, and I know Heidi, you should chime in on this one. You get this one a lot, and so do you, Dawn. Well, isn't just substituting Suboxone, for another addictive drug? Like, why don't we just be clean clean? See right there, stigma language in remission. Why don't we just avoid opioids altogether? Again, if it helps you to kind of talk through the properties of buprenorphine, that it, is safer, that it lacks the euphoric effects. If you need to, you can, cite the evidence base that we know people that take methadone and buprenorphine, these long-acting agonists, it helps keep patients healthier, decreases their risks of legal troubles, and decreases their risks of infections like hepatitis and HIV. So yeah, I don't know, Dawn, Heidi, did you have any thoughts on, I'm sure you get this question a lot as care managers treating OUD. What are your thoughts on this common question?
Yeah, I've had patients tell me that if they, let's say they misuse their Suboxone or they use an opioid outside and they get taken off their Suboxone regimen for whatever reason, they say that they have a worse withdrawal from Suboxone than they do an opioid.
Okay.
Which I know, and I'm always like, oh, okay, is this true, or is this just how they feel, because they're wanting, and I think you're going to mention coming off of the Suboxone so they can get the high from the opioid that they are choosing to take at that point. And so in their mind, they may be already craving before they even get there. So there's always probably a background story for the patient, that maybe they when they start speaking that language of it's a worse withdrawal. I don't know that it could be actually worse. But talking them through that, and for me as a care manager, I'm consistently talking to them about lifestyle. It's a completely different lifestyle being on Suboxone. But that lifestyle is also social change a lot of times. And so that's the more difficult part, especially if they live in a community where there are a lot of users, and they are constantly being solicited. So anyways, that's been my experience with that part of it. And them saying, well, what's the difference? I'm still addicted. I've also had patients, and if I can say this real quick, Dawn, I don't mean to take up any more of your time either, but I have had them ask me, at what point can I say I'm no longer an addict, especially if they're going to start dating or something like that, right? And they don't want to have to reveal their whole life story if they've been on, let's say, Suboxone for 3 to 5 years. And that's a hard question to help them answer about, how truthful do they have to be about the struggles that they have, have occurred throughout their life up until this point, right? And Suboxone has actually released them from that. And so helping them find language around that and helping them navigate relationships around that. So that's been my experience.
Absolutely. Excellent points, Heidi, for sure. Dawn, did you want to chime in anything on this topic?
Yes, yeah. Can you guys hear me? Okay. Okay. I was going to actually comment on this. Is just another opportunity for a teaching point, kind of exploring their past history of attempts to stop, and then giving them that demonstrating hope with how Suboxone can be helpful, and kind of helping walk them through that concern. Also, I did want to comment on, I too have heard others say that it feels like it's worse of a withdrawal, but then that's also a time for us to like kind of explore, well, how are you reducing your Suboxone? Is it through your provider? Have you discussed this with your provider? Because I feel like, especially you, Dr. Thomas, I know that you know so much about the prescription and how to properly prescribe this medication. So kind of using your expertise as well to kind of help guide the patient. That's where I think the collaborative care model and addressing OUD really comes in handy for these patients, because I don't feel like I have to have all those answers. I have you to pull from. I have other providers that I work with as well. So and then ensuring that the patient knows that they have the support, so they can feel as if they can discuss those topics that are challenging, have been challenging in the past.
Yeah, absolutely. Yes, no, for sure. Collaborative care model is set up beautifully to help with primary care treating OUD, just because of that very point of the interdisciplinary team, right? You got the care manager that can check in between medication follow-up visits. You've got your psychiatrist consultant that they can chime in on dosing, and then of course treating the co-occurring mental health issues. So yeah, it definitely helps to have that team. And in busy primary care practice, you may not have that staff availability to do those check-ins, right? If it's just message the MA or the nurse on your team, they might have, dozens and dozens of, triage messages they're going through. So it's nice to have that extra teammate and the care manager to help do that check-in and monitoring for sure. And yeah, Heidi, I love your question of something like, well, how long do I need to say I'm an addict? I mean, I think that's a very, personal question. At least in the training I've got, there was a lot of teaching points around helping people reframe this as a chronic condition. And if that helps them use language more around the lens of, okay, this is a use disorder that we're managing, we're treating with medication, prescription medication. It's common to have, relapse and remittance, but that's the nature of chronic disease, right? Diabetics will go through episodes where things are good and they're under control, and then, they might have a relapse where we have to adjust meds and adjust course, and that's normal for chronic disease. So I think normalizing that and helping people think of it that way with less of the stigma, and there's a lot of stigma, don't get me wrong. I mean, patients can have a whole lot of psychological burden of very stigmatizing experiences they've had with use disorders, but I think anything we can do to show them that, like, hey, we're looking at this as a chronic disease, we're going to treat it, we're going to roll with resistance, we're going to expect some ups and downs, and that's okay, we're here for you. I think people find that very helpful.
So Jen, I'm just gonna a couple of comments in the chat really quick. So Eric Christian, I think this is when you were talking about some of the withdrawal that ondansetron seems to be highly effective in helping with nausea and has an oral film that acts really quickly. So he was just observing that. And then Patty Gibson also observing that she has also heard from patients that the withdrawal from buprenorphine feels worse than other opiates.
Yeah, I've heard that from folks too. So we, anticipate that, right? We might say, yep, that's not, I think, validating people's concerns, right? Like, you're not crazy, you're not overreacting. This can be tough. How can we help you get through these symptoms, and what's your, goal of use, and how can we help support that? Great. Okay. Thanks, Diane. Other things that will come up, patients will almost always ask you, well, what happens if I relapse, right? Because again, chronic disease, relapse remitting, talking through that. Well, again, buprenorphine, think of it as a tighter bind to that receptor. So if you're taking your Suboxone every day and then you have a use of, say, heroin, it's going to be tougher for that heroin to get in that receptor group because buprenorphine is really tightly bound there. So the heroin will be less effective. Not that it'll have no effect, but it'll definitely have very limited effect if all those receptors are occupied by buprenorphine. So that's how it's kind of protective in that way. Now, as Heidi was saying, a lot of patients, you will see kind of a lot of starting and stopping. They'll come in and they'll get on buprenorphine and they're doing good for a few weeks, and then maybe don't hear from them for a month or two. And when they follow up, it's, I stopped the Suboxone, then I used for a few days, I want to get back on it. That happens a lot. And that was one observation that as a new prescriber in primary care, that concerned me at first, like, oh, am I doing something wrong, right? Is it like, am I dosing them enough? What's wrong? We need to talk to them more. But again, mentors, the addiction specialists that we talk to, you'll find like that can happen, and that's very normal. So just saying, okay, what is our approach here? What's your goal for your use? You know, are you in a place where you want to abstain completely from fentanyl or heroin, or are you more interested in harm reduction, right? You're just knowing that there's fentanyl on the drug supply, you're worried about overdose. Maybe we're just trying to avoid or decrease the fentanyl use that you have. So really hammering home that meet patient where they're at. That was just a learning point, a growth point for me as a PCP. I think, you know, we get in that mindset of like, well, you have diabetes, you take meds, you get the A1C under 7, woo, we're good, we win, right? You check the box. I don't know. I think you just have to kind of reframe your goals there of really partnering with the patient. What's their goal? If they're coming in to see you at all, if you're having a chance to engage with them, that's a win. So anytime you can have that opportunity to discuss decreased use and harm reduction, even if abstinence isn't part of the plan, that's okay. So yeah, that's just definitely something we've learned by doing. The fentanyl era, unfortunately, fentanyl is all over the drug supply. It's a synthetic opiate, very potent. DEA has some good infographics here. Sadly, 6 out of 10 pills that the DEA seizes off the street supply have a lethal dose of fentanyl. There's a lot of counterfeit pills out there. The brightly colored Oxycontin fake tabs there have fentanyl in them, and 6 out of 10 of those could have a fatal dose. So even one pill, unfortunately, could be deadly. And you look at that tiny amount on the tip of the pencil of how much fentanyl it would take to potentially kill someone. It's pretty scary. So fentanyl, why is it such a scourge? You know, it's short acting, but it's lipophilic. So it hangs out in your fat cells. So it feels and looks like a long acting opioid. So it might take 2 or 3 days to get that fentanyl out of your system to have enough receptors open to start Suboxone. So again, it just makes induction a little more complex. And again, is certainly higher risk for mortality. So adolescents, and we got some chat on the email listserv about like, hey, can we talk a little bit about how this affects peds and adolescents and young adults? Because it certainly does.
Hey, Jennifer, can I ask a question just based on that last slide?
Yes, go for it.
I've, you know, and I can't speak for the physicians here, but I have noticed that if a patient comes in, let's say they've overdosed on fentanyl, that they want to start them on methadone rather than go to Suboxone because they don't think they can get Suboxone high enough. Do you guys, I mean, and I saw your slides about the Suboxone. So I'm just curious about what, you know, at 24 milligrams, is that sufficient to transition a patient?
Oh, good question. And by all means, if there's any addiction docs on the call with more experience than I have, only done this about 3 years, please chime in. In my training and experience, you were correct in that with fentanyl, oftentimes we have to go higher than 24. What's the ceiling? It's going to depend on, you know, the patient and the comfort level of the prescriber. But yes, absolutely, to your point, that 24 milligrams oftentimes is not enough. We have, even in primary care, I've got a handful of patients on 32 and 36 milligrams. The addiction docs will tell you they can even go higher than that. So again, I think collaborative care, right? Collaboration. If you have other specialists on the team, and not, I don't know that every psychiatrist on your CoCM team will have that expertise, but hopefully they do, but having that ability to consult, because if you're in rural practice like we are, you know, the next best thing is here's a phone number for Stepping Stones in Joliet, Illinois, 30 minutes away, and the nearest methadone clinic's an hour away. Man, like that's a really tough situation for people to be in if that's their only other options. Not to say methadone is not great. Methadone is a fantastic med for some folks. It's a tool in the toolkit. Maybe they choose that and it works for them. Great, keep taking it. But you're right that in the fentanyl era, you know, inductions and getting people stable on buprenorphine can be more challenging. But don't give up. It's definitely something worth a try. Anecdotally, I'd say the Sublocade shot has been helpful for some of our very severe OUD patients. The Sublocade is buprenorphine in the sub-Q fat, and it releases steady state over the month. So for some folks that have a lot of that compliance and then relapse very rapidly, that might be another option to keep them stabilized. But yeah, I think you know, if methadone is available and you have access, that's what the patient wants to do, by all means, you know, some treatment, any treatment, we're happy to connect patients.
and to that point too is like when you said, if you're in a rural community, where is there a methadone clinic? And
Right.
and many times it is that they have to go every single day to pick up that
Right.
one pill, and then
Yes.
I guess they get their lockbox over the weekend or whatever. But
Yeah.
it is, that makes it so much more difficult. And
Yep.
whenever I talk to patients that are like on a methadone regimen versus a Suboxone regimen, but they'd like to be on Suboxone, it is that transition of being able to get to the Suboxone that is always difficult from the methadone. So I'm always like, well, it's best to get them on Suboxone firsthand. And yeah, and I guess it's going to take other clinics that are almost experimenting with those dosages to see
Yeah.
what is possible.
Yep.
So.
Yeah. Absolutely. Were there other comments? I don't want to cut anybody off. Nope. Okay. All right. So adolescents. So unfortunately, the counterfeit pills are widely available, and a lot of young adults, adolescents might use some of these as study drugs. In fact, on the dark web and social media referrals, these figures here show counterfeit versus legitimate oxycodone, Adderall, and Xanax tabs, and they're pretty darn close. So if we, to Joe's point, oh, I would never take anything off the street. Oh, this looks like a legit, tab that would have come from CVS or Walgreens. You may not know, and even his friend may not know because he got it from somebody who got it from somebody else. So just hammering home that, with fentanyl being in some of these street drugs, just be very careful that unfortunately the counterfeit pills can look very similar. A lot of young people might start, using Xanax or Adderall as study drugs, right? There's that misconception of, oh, it'll help me do better on my finals and perform better. But there's actually evidence that those non-medical uses of prescription stimulants don't show better academic performance. So even though we might think that it helps us stay awake longer to study more, it certainly can be very risky. And this was just a terrifying and interesting infographic of emojis, so that people, if they're on the market looking for Percocet or Adderall, they might be using these emojis to connect with referrals. So,
and Jennifer, I actually have a very horrific story
oh,
about a patient that was taking blues, went to a neighbor to talk to her about, what she was struggling with. And her neighbor offered her a blue and said, oh, no, it's a prescription. And she took it, she got back in her car and started driving. And for some reason, it had a latent effect. And she ended up ODing while she was driving. And she talked about, she's clean right now, but and on medication, but she talked about how that trust, but it's like you said, who knows where she got, her neighbor got it, who knows? And it goes like that.
Absolutely. And those emotional traumas, there's rippling effects of that affect so many others, not just the folks that are in that situation. So yeah, just can't be too careful with that. Thanks. That's a good story, Heidi. Okay.
So Jen, another question from Eric, and actually Eric, if you could unmute yourself and maybe ask that. I think when Jen's sharing her screen, it's hard to also see the chat box.
Okay.
Sure. Well, Laura had commented, we were talking about the ondansetron and how it comes, in an oral film formulation, which really dissolves very quickly. And I've seen people with extreme nausea come around quickly. But Laura was asking about mitigating risk for serotonin toxicity, if they may also be on an antidepressant due to the ondansetron's serotonin effects.
Sure. So like risk of serotonin syndrome, if you're on, say, sertraline or fluoxetine, and then you get ondansetron for nausea, is that kind of the question?
Yeah, I've seen like in case review and then just working in primary care environments, a lot of people on the spectrum of serotonin toxicity, not as much like full-blown serotonin syndrome, but certainly with dilated pupils, difficulty with ataxia, going in and out of the ER, these unexplained falls, having issues with the diarrhea. And often they'll kind of have a regimen with multiple serotonergic agents. And, the concern being with the opioid and the, ondansetron, and then if they have an antidepressant on top of that elevated risk. So just, would love some guidance on monitoring for that, or how you guys are navigating sort of those risks and benefits as part of this work?
Yeah, I mean, to be honest, I would say that's where we're leaning on our consulting psychiatrists to help us, because in primary care, we're saying, all right, we do a lot of SSRIs, you know, ondansetron can be used, but what's the risk benefit here? It's tough. I think it's case by case. You have to have a good informed team and talk through those situations. But just being aware of that, I think it's good to talk it through with your team, because otherwise it's the PCP all by themselves freaking out and be like, I don't know what to do. You know, can I give this Zofran safely, and somebody's miserable, otherwise going to the ER? You might be able to, right? Maybe it's a smaller dose of SSRI. So I think that's where we lean on people like Laura and be like, hey, psychiatrist, help me figure out if this benefit is worth risk. So I hope that helps. I don't know. All right, cool.
Sounds good. Yep.
All right, very good. So yeah, collaborative care, where does this come in? I mean, screening is the cornerstone of what we do with collaborative care, right? That PHQ-9 screen, and then the subsequent monitoring, measurement-based treatment to target, that is 100% of part of what we do with collaborative care. So if we wanted to weave in opioid use disorder, or really just screening for any substance use disorder, where are you going to start? Your team will probably go, well, how are we screening for depression currently? Well, okay, the MA does it when they room the patient, or if we do a telemed visit, they do it verbally, or we send them the link and they can do it electronically. So you probably already doing a lot of substance use screening in your primary care clinics. Most PCPs will be screening for tobacco and alcohol use. So maybe you think about incorporating something like the DAST. So this is a evidence-based screener that's only 10 questions. Perhaps this is a way that you can add to your arsenal of how you screen for use disorder in the primary care setting. Should we be screening for OUD in primary care? So this is the big question of CHAMP, right? So this research study that UW AIMS Center is working on, that Heidi, Don, and I are part of. And that's one of the aims of this whole study, right? Is can we screen for OUD effectively in the primary care setting? What screeners should we use? And then also we're looking at, does collaborative care help those folks with both OUD and mental health? So, and I don't know, Diane, if you want to talk more on this, but the CHAMP study has been awesome. There's publication, a qualitative study that came out. There's one that they're hoping to get published soon too. I guess anecdotally, I'd say that OUD, we're finding that enrollment, there's maybe not as many folks coming to primary care with OUD to seek treatment. And then there's a lot of, you know, discussion on why that is. Maybe they didn't know that that was available in their community. Maybe folks with OUD are in crisis mode. Maybe they're not coming in for preventative visits like other people in the population. But CHAMP has definitely, I think, at least in our experiences, helped us in primary care just be more aware that this is something we can look at and treat with a little extra support and education. Yeah, it's a chronic disease and it's part of all of our communities. So I don't know if you want to talk any more about CHAMP, Diane, but it's great.
I'll just, to the point that you were making, I'll put a link to the paper that you were talking about in the chat, and it talks about, you know, routine screening for opioid use disorder in primary care settings. So I'll put that in the chat for anybody who's interested in following up on that.
Awesome. Thanks, Diane. Okay. What about the adolescents? What does AAP say? Well, AAP recommends that pediatricians and people that take care of children should increase their capacity for substance use detection. Think about expert practices. Interestingly, the U.S. Preventative Service Task Force does say there's evidence to support it for adults, but that there's insufficient evidence to support for adolescents. So where do we take this? I mean, I think that'd be an interesting conversation to hear you guys chime in. What are you doing if you're seeing kids? Do you do substance screening at your well checks? If so, how do you do it? Do you just ask? Do you have a screening form? We don't use the CRAFT, but in preparing for this, I was like, oh, I didn't even know this was out there. So there's always opportunities to learn. So CRAFT is evidence-based 12 to 21. It's brief. You might, if this, again, maybe it's a QI project for your CoCM program, that if you take care of kids, maybe you want to incorporate some, you know, operationalize screening for substance use in your teen and adolescent population. So again, collaborative care has a really good framework with things like PHQ-9 that you could bake in some of those additional evidence-based screeners if you wanted to incorporate that in your collaborative care work. And then what about buprenorphine in adolescents? So PCSS has a good guidance paper on this. Feel free to check it out. Bottom line, it's approved for 16 and older, the buprenorphine. There's a lack of data for kids under 16. They recommend involving the parents whenever possible. Now, again, this is not to say that you would, you know, break confidentiality, but if possible, engage the patient and their parent in that conversation. Ask the adolescent, can we talk about this with your parents, the diagnosis and the treatment? Oftentimes parents will know that something's going on and maybe they've helped bring the child in for assessment. So if the child's okay with that, any chance you can partner with a family and the support network is a good thing. But of course, you can protect that therapeutic relationship. You don't have to share all of their details, with the parent that don't affect treatment. Keeping that rapport between you and the clinician is important. But just be cognizant of the laws in your state. Some states you have to have written parental consent to use meds for OUD. But this is just a good resource if you're treating adolescents and teens. And I personally haven't treated anyone under 18 with buprenorphine. I'd be curious if there's folks on the call that have that population and how that's going. So it's possible, but certainly, like we saw with the exposure of substances, kids are being exposed to substances. So we just kind of need to be more cognizant of that and doing more screening for that in primary care. So how about CoCM, right? How often is this going to happen? Well, apparently 62% of people with OUD, maybe it's even more, feels like, have a co-occurring mental health illness. So if you're doing collaborative care, substance use disorder, and especially OUD is probably going to come into the picture. So I'd love to hear from Heidi and Dawn, your care managers. How do you weave in your evidence-based psychotherapies, your BA, your CBT work to help with not just the mental health, but when you have the OUD going on? How do you bake that in to help patients achieve goals?
I do use the behavioral activation model because that's the UW model. It doesn't mean that we don't cross over a little bit into some CBT as far as just how they're doing on redirecting, especially if they're having cravings or something like that. We might do a CBT exercise. But behavioral activation, and I think it's kind of like what Dawn talked about actually, and I'll let her speak on that. But it is finding out where the patient has been resilient kind of in the past and maybe implementing what they have learned throughout their life that helps them cope better, as well as getting them to focus on a single goal. And it can be a very small goal that they can accomplish during the week. And I mean, it could be literally like getting out of bed to take a shower daily. And once they've accomplished that goal, and we talk about, how did that make them feel, and they can kind of integrate that as a part of their routine. And then once they start building this routine, they become stronger about really trusting themselves to make executive decisions. So it's a really strange way to get the executive functioning going in patients. I'm typically used to working with patients in a slightly different way than that, but I think it's very, very necessary to start very, very small with somebody who has OUD. And from my experience, and I saw somebody had asked, well, how long does a patient stay in like a program, whether it's a collaborative team program or even in psychotherapy? I would say possibly for the rest of their life. It's kind of like this consistent developmental process. But 2 years seems to be about at the point, if the patient has been able to stay clean long enough and they have changed their social system. 2 years is when their brain kind of just clicks in, and I'm sure Linda could probably feed into that too, about how long does it take for a person's brain to kind of rewire themselves and realize, I'm now living this life and not that life. So those are my thoughts.
Great, thank you.
I want to second your 2 years because, yeah, definitely providing patients with that support. I've got a patient that I've been seeing for a little over 2 years. And one of the things that not only this patient has mentioned, but other patients that I've worked with that have an OUD diagnosis is feeling heard and not non-judgmental, because it's their story, what they've gone through. It's important for them to express it, but it's also just that it's so important for us to be able to utilize our active listening skills. And I do a lot of motivational interviewing as well, to be able to kind of hone in on what the patient wants out of this treatment because it's their treatment. It's not my agenda. And I know in the very beginning of all this, when like harm reduction came out, I remember having such a difficult time with that model. And that was probably because in the past, it was always strictly accidents, you know, and harm reduction was a different way to look at it. But I completely embrace the harm reduction model now, because it's what's the lesser of the evils, you know. Do I think that, you know, maybe a person that's smoking a little bit of cannabis to help with a little bit of anxiety, would I look at them differently? No. If that's what's working for them, then, you know, that's the lesser. If it's creating some of those other issues, then yeah, then maybe it's a good conversation to have. Timing is of the essence with those kinds of conversations, though. So really just allowing the patient to guide me through, because I know all of us, we all learn so much from the people that we work with. I mean, you were showing those colorful, assortment of pills. And as soon as I seen that, I remembered what a patient of mine said just last week about Skittles. And I didn't realize that's what these kids are calling those things today. And it's like, wow, you know, just really, it's very rewarding work. And I hope I'm not rambling.
No, not at all.
I
Not
tend
at
to
all.
ramble sometimes.
All good. No, it's great. It's great. Thank you.
All right, well, we have a few more minutes. I know we've had questions and conversation, you know, in the chat and also from folks as we've been going along, but other questions, observations, comments, etc.
I mentioned this to Jennifer just in an email. It's just that I think the recidivism of opioid use is probably pretty high, but there are still those patients that are working towards the goal, and it is almost like a cognitive change that they're approaching to say, I am now wanting to be actively in maintenance. I want to be actively getting well, and being there for them and being ready for that moment to grab hold with them, I think is extremely important in this collaborative care. You can get, I guess, disappointed sometimes as a clinician, and I have learned that they will eventually come back. It was kind of, and we've been in this program for almost 2 years now, and to see them come back 5 or 6 months later, just because they're getting back on Suboxone and they tell the PCP, hey, I know Heidi reached out to me several times and I didn't call back, but I would like her to reach out to me again. And I get that message. And so you realize, okay, they're still out there. They're still trying. They're trying to figure this thing out. And so staying ready for that. I just want to be an encouragement.
Any other questions, comments?
I've got a question. It's about coding. Just sort of what people are doing for coding with MAT. You know, sometimes as people start to get into care, they're feeling better, then they start mentioning some of the things that they've been putting on the back burner. And so how would the PCP code the MAT visit and then other conditions on the same day? Are they putting that all on one appointment, or how are they maximizing coding?
Yeah, so I would just say it bakes into what you do in primary care. So it's probably going to be a level 4 if you're, you know, addressing multiple chronic conditions, but it's part of your work as a PCP. So if you have diagnosis OUD and generalized anxiety disorder, PTSD, and maybe you're refilling their hypertension, that you're coding the same way you would for chronic disease. Now, the collaborative care model, that's going to be time-based codes
Sure.
that your Dawn or Heidi will put in for their work in conjunction with the site consultant. But yeah, for your med visits, it's just regular primary care codes and like any other chronic disease. Does that help? I hope.
It does. Yeah, I think in some cases they're maybe trying to kind of capture 2 events, 1 visit. I don't know.
Sure, and it can be complex with timing. I will say that real quick. If you're a busy PCP and, you know, like the time is now, if someone's like, I want to get on Suboxone today, having acute slots open or just being really nimble and squeezing them in, having a PCP embrace that mentality of I will work you in. We're going to get really efficient with charting because, yeah, if they're here today and want treatment, that's great. One less use can literally save their life. So figuring out how to get them in when they're ready to be seen is important. But culture shift, right? That's anything in integration.
Thank you.
All right, well, we are out of time. I really want to thank Heidi and Dawn and Jen for their work today and for sharing their experiences. Jen, I hope you have a chance to look really quickly in the chat. Many people have said, and Heidi and Dawn also, that this has been really helpful, that they really appreciate this topic. And one specific shout out to, or two actually, to you, Jen, that people love hearing from you in this group when you present. And you know, and I think it was Mark who said we need to get you in front of our providers. So so anyway, really, yeah, really appreciate the topic today and everyone's participation, and we'll see you next month. Take care, everyone.